So ankle joint and foot is our final section in the Unit 3 that we're going to talk about. Alright, so the next few slides are actually pictures that we labeled. These are slides that you guys can copy, print, and actually label them yourself to give you guys some times to practice. You'll see these types of diagrams on exams or quizzes. So just be prepared and know the different bones and landmarks that we've got labeled here. The reason we do this is because when you talk about an injury with a patient and the diagnosis is a grade 3 ankle sprain on the lateral side, you got to know which ligament has been affected, which muscle's been affected, and where the origin or insertion is. Sorry. Okay, so A, B, C, and D here, as far as on the left upper part, you've got the motions that the ankle performs. So A is dorsiflexion, B is plantar flexion, C is inversion, and D is eversion. You've got E and F. Actually, let me switch that around. C is considered more of a supination, and D is a pronation of the foot, and then E is inversion, F is eversion. What I will do is just clarify that a little more for you guys once we get into the lecture portion in the class. If you're an online student, keep in mind, just look in your book and keep in mind those motions. Typically we talk more about the inversion eversion aspect of the ankle versus pronation supination. So and then of course over to the right you've got different sections of the foot that you'll need to know as far as the phalanges, the metatarsals, and the tarsals. And then a part of the phalanges, you've got, as far as the great toe goes, you have the interphalangeal and the metatarsal phalangeal joint. That's the IP and the MTP. And on the rest of the lesser toes, you've got the distal interphalangeal, the proximal interphalangeal, and the metatarsal phalangeal joints. And again, just some more labeling for you, and we're going to discuss bones and landmarks real fast. These should be a review for you, but we'll just go over them again. Tibia, crest, medial malleolus, fibula, the head of the fibula, lateral malleolus, and interosseous membrane. Interosseous membrane, you can't palpate, you just have to visualize where it's at based on the other landmarks. Go ahead and make sure that you are able to identify those on your own body, as in class we will practice on each other where to find these bones and landmarks. And we just discussed that a little bit. You've got the phalanges, the metatarsals, and the tarsals. Okay, as far as the tarsals go, you've got the, excuse me, for the bones and bony landmarks, calcaneus, the talus, the navicular tuberosity, cuboid, first cuneiform, second cuneiform, and third cuneiform. The calcaneus region, you've got the calcaneal tuberosity, sustentaculum tali, the medial superior part. This projects out from the rest of the bone. It supports the medial side of the talus. 3 tendons will loop around, changing direction from the posterior leg to the plantar foot. And again, this is something that we will go into more depth in the classroom. And then the metatarsals, this is the section labeled I. You have them numbered 1 through 5. Your big toe is labeled 1. And then of course the 5th is going to be your pinky toe region, but more at the base because it's the metatarsals we're talking about. The 1st and 5th are weight-bearing bones. That's important to know. 2nd, 3rd, and 4th are not. So if you stop and think about even going to like Walmart or Walgreens or somewhere where you can stand on those machines and it tells you, it's over by the pharmacy, and it tells you based on where you disperse your weight what kind of heel cushion or foot support you might need for your body. Next time you go in there, try one of those machines and see if you're bearing your weight through the 1st and 5th metatarsals. It's pretty interesting to look at that. Landmarks, you got the base, which is the proximal region, and then the head of the metatarsal, which is the distal region. You're going to find that the head is a convex side of the bone, and then the base is concave. And a good example is, this is concavity, which is the base, and this is convex, which is the head. And then of course the phalanges. So your first digit here, labeled J, this is your great toe or your big toe. And then you've got the 2nd, 3rd, 4th, and 5th. So these are considered the 4 lesser toes. In the 4 lesser toes, you have the proximal, middle, and distal phalanx. In the great toe, all you have are the proximal and the distal phalanx. Let's see, again, the base is concave and the head is convex. As far as functional aspects go, we got the hind foot, the midfoot, and the forefoot. So the hind foot is the talus and the calcaneus. This is what should contact the ground first in gait. What that means is when we go to take a step while we're walking, our heel should strike first. This will influence the rest of the foot and which direction the rest of the foot will go, and how it will lay down on the ground. Your midfoot, right here is the navicular cuboid and the cuneiforms. This provides the stability and mobility for the rest of the foot. And then of course your forefoot, metatarsals and phalanges, this will adapt to whatever ground you are walking on. We put level ground, but you know, if you're walking in a gravel parking lot, your heel is going to strike first. Your midfoot will provide the stability to keep your balance, and your toes and your, of course, metatarsals will be what actually adjusts and adapts to the ground. I don't know why it did that. Okay, so we talked a little bit ago about supination and pronation of the foot. All supination is a combination of plantar flexion, inversion, and adduction of the foot. And I'll give you a visual of that, or if you want to, you can actually Google supination of the ankle and find videos just on the actual motion. That's fine. And then of course pronation is dorsiflexion, eversion, and abduction of the foot. We're going to talk just a little bit about the tibiofibular joints. There are 2 of them, A and B. You've got the superior tibiofibular and the inferior tibiofibular. Neither of these are part of the ankle joint, but they do have a role, especially the inferior tibiofibular. The superior is a non-axial plane joint. Remember, non-axial means there's no movement. There is a joint capsule, and it's reinforced by ligaments that run through. Then the inferior tibiofibular has more of a fibrous union. There's no joint capsule down here, and the fibrous tissue separating the bones, and it holds the joint together. As far as the ankle joint goes, we call this the talocrural. It's also known as we also have the talotibial joint. So what we will do is discuss the different sections of the joint. The talocrural talotibial joint is synovial uniaxial. Uniaxial means there's only one movement here. It's plantar flexion and dorsiflexion, so up and down like you're pumping a gas pedal. It's considered a tendon and mortise joint. The reason that we call it the tendon and mortise joint is because it's locked together in like a hinge. Make sure you know that plantar flexion and dorsiflexion occur in this joint, and these are your degrees of motion, and we will have already discussed that some in class, but we'll go over that again as far as the angles and being able to visualize the amount of motion. This is also the true ankle joint, and that needs to be written down. Just make sure you know that it's the true ankle joint, and plantar flexion and dorsiflexion occur here. Subtalar joint, this is the talocalcaneal joint. It consists of the inferior surface of the talus and the superior surface of the calcaneus. It's inseparable from the transverse tarsal joint. So what you're going to get here is more of a gliding motion. Inversion and eversion occur here, and you get about 5 degrees of each. And so know that the subtalar joint, also called the talocalcaneal joint, is where inversion and eversion occur. Let's see, the transverse tarsal joint or the mid-tarsal joint consists of the anterior talus and calcaneus, so right through here, and the posterior section of the navicular and cuboid bone through here. There's very little motion here. There's a combination movements of pronation and supination. This will help cause inversion and eversion in the hind foot and forefoot, but again, the talocalcaneal joint is what actually creates the inversion and eversion, or where the motion is, I'm sorry. All right, and then we talked a little bit about the metatarsal phalangeal joint, named for where it's located. This is the metatarsal, and this is the one of the phalanges. So here's the metatarsal phalangeal joint. We have those in all 5 of the toes. As far as the great toe, all you have on top of that in addition to is the interphalangeal joint, and in digits 2 through 5 you've got the distal interphalangeal joint and the proximal interphalangeal joint here. There's as far as mobility goes, the great toe is your most mobile. You have about 45 degrees of flexion and about 90 degrees of hyperextension. Digits 2 through 5 are less mobile. You get about 40 degrees of flexion and only about 45 degrees of hyperextension in the other digits. And that's in the MTP joint itself. Point of reference is always the second metatarsal. When we discuss ab and adduction, because the second metatarsal is the point of reference, it's what the other toes are doing. So if the other toes are moving medially or laterally from that second toe, that's abduction. If you're returning from abduction, that's considered adduction. Oh, and just a side note here, when we talk about the second metatarsal as the point of reference, there's no true midline to pass when it comes to adduction. All right, and then the interphalangeal joints, the digits 2 through 5, we've talked about that. You've got the PIP, the DIP, and then in the great toe, all you have is the IP. The ankle joint capsule, this is thin anterior and posterior. Medially, you've got the deltoid ligament. Laterally, you've got three different types of ligaments: the anterior talofibular, the calcaneofibular, and the posterior talofibular. They are the main ones that I want to discuss. There are tons of other ligaments that attach to the different tarsals and metatarsals, but we're not going to go into those, only because these are considered the most important. And I will say, your joint capsule is thin, anterior and posterior, but it's reinforced on each side by collateral ligaments. Excuse me. Medial ankle ligaments, you've got the deltoid ligament, which is the medial collateral. This strengthens the medial side of the ankle, holds the calcaneus and the navicular against the talus. Helps to maintain the medial longitudinal arch, and these are all important to know about the medial ankle ligaments. The lateral ankle ligaments, you've got the lateral ligament, posterior tibiofibular ligament, anterior tibiofibular ligament, and the long plantar ligament. So the lateral ankle ligament attaches to the lateral malleolus and the talus and calcaneus. There are three parts. You've got the anterior talofibular, which is a pretty weak part of this ligament. You've got the calcaneofibular ligament, which runs vertically right through here, and the posterior talofibular, which is one of the stronger ligaments you're going to see. This provides lateral stability. It's the one that's most often injured. If you stop and think about that, if anyone's ever rolled their ankle, when you go to take a step and you end up rolling that ankle, your foot tends to roll inward, or that inversion motion or supination motion, which would create an overstretching on the lateral side. All of these would pull away from each other and damage when you do roll your ankle, and so that's why it's the most often injured. Arches in the foot. Let's see. Foot must be able to absorb shock, adjust to changes in the terrain, and propel the body forward. The bones of the foot are arranged in arches. If you stand on a triangle, you're going to have a weight bearing from the base of the calcaneus, right here, to the heads of the first and fifth metatarsal. So it creates a triangle. And again, if you stand on one of those machines, you'll see there's redness where you bear the most weight, and these are the areas that should be red. Okay. Three arches. You've got the medial longitudinal arch, the lateral longitudinal arch, and the transverse arch. Medial longitudinal arch runs from the medial border of the foot from the calcaneus. It goes through the talus and the navicular and the three cuneiforms, and it ends up on metatarsals 1 through 3. The talus is the keystone here. It's the top of the arch, and it receives the weight of the body. Normally, it depresses during weight bearing and recoils when the weight is removed. Make sure you know that the talus receives the weight of the body. That's important. The lateral longitudinal arch runs from the calcaneus anteriorly through the cuboid to the metatarsals 4 and 5. And so remember, 4 and 5 are on the outer part of the foot. That's why we call it the lateral longitudinal arch, because it's named for where it's placed. This will rest on the ground during weight bearing. The transverse longitudinal arch, transverse means across, so it runs from side to side, goes through the three cuneiforms to the cuboid. The second cuneiform is the keystone of this arch. Arches are maintained. So how are they maintained? Shape of the bones and their relation to each other, plantar ligaments and the aponeurosis, and muscles. So aponeurosis is also called fascia, and we will discuss that a little more in class, but just make sure you're prepared. It's that thin layer, it's like a sheath that will assist in adding a little more strength to that arch. There's no bone present in this area here, but great strength is needed when you are standing and creating an arch in your foot, and so it's got to be fit and strong and thick here. All right. Of course, the support structures of the foot, you've got A, B, C, and D, spring ligament, the long plantar ligament, the short plantar ligament, and the plantar aponeurosis. Spring ligament attaches to the calcaneus. It runs forward to the navicular, right here. It's short and wide and most important, so make sure you know this. Supports and strengthens the medial side of the longitudinal arch. If it's not doing its job correctly, it can cause, or what's caused, pes planus. Again, if it's not doing its job correctly, the pes planus means flat foot, so the arch is not maintained. So the arch will fall and create just a flat walking motion. So we will probably talk about that a little bit in class, and I'll just find out who might have just more of a flatter foot, or who feels like they don't have a very high arch, and we'll look at that. The long plantar ligament, it's the longest of the tarsal ligaments. It's more superficial than the spring ligament. It attaches to the calcaneus and runs forward to the cuboid and the bases of metatarsals 3 through 5. It supports the lateral longitudinal arch. So it's right through here. And I've pulled out from the book what I think is important and what you all need to know. Short plantar ligament, right here, attaches to the calcaneus and the cuboid. It helps to support the lateral longitudinal arch. And the plantar aponeurosis, also called fascia, it runs from the calcaneus to the proximal phalanges. So it runs all the way through here. And remember, it's not a muscle or a ligament. It's like a sheath, and it's pretty strong, or it needs to be pretty strong. It helps to support the arch as well. It acts as a tie rod, so it keeps the posterior from separating from the anterior. When we discuss this, we will go into a little more detail about what's called plantar fasciitis, pretty common diagnosis that you'll see in the clinics, and we'll discuss why we get that, and what it causes, what it creates. Other support for the arches, about 15 to 20% are supported by the inverters and everters, so the muscles. Medially, you've got the tibialis posterior, the flexor hallucis longus, and the flexor digitorum longus, and then laterally the peroneus longus. As you can tell, the muscles that are in the foot region and the toes, especially, a lot of those are named for what they do. Hallucis is great toe, so flexes the great toe. It's the longer muscle that flexes the great toe. Flexor digitorum, longer muscle that flexes the rest of the digits. Muscles of the ankle and foot. So extrinsic muscles, they originate on the leg. They're found in groups of 3 or combinations of 3, and they're located in 3 anatomical areas. The intrinsic muscles will originate on the tarsal bones themselves. So the rest of these I want you to get familiar with. We will discuss a little more in class why these are important, and we'll be able to palpate quite a few of them. And then of course we'll go into the intrinsic muscles. As you can tell, you don't need to know origin insertion. I just need you to know the action of these muscles. And let's see, last thing I want to talk about here is the calcaneal position. You will see this when you have patients that present with maybe a little bit of an abnormal gait, if they're complaining of ankle pain, if they've had sprained ankles in the past, or if they have a current diagnosis of something going on with their ankle. You know, a lot of what we do can be visual, and we need to be able to visually assess our patients, and this is one way that we do that, by looking at the calcaneal position. And so if you're looking at a patient while their back is turned to you, typically I'll have them take off their shoes and socks so that I can look and see if, first of all, if they're symmetrical, which means equal on both sides, and I just also look at the placement of the calcaneus. So this is going to be a neutral position. Everything looks pretty even. Lateral side, you've got the lateral malleolus, and then of course the medial malleolus, and everything looks in pretty good alignment. Calcaneal valgus, this is where the distal segment moves away from the midline, and then the calcaneal varus is where the distal segment moves toward the midline. So remember, this is the distal segment, it's moving toward the middle, and then of course the distal segment is moving away from the middle, and this is considered your distal segment here. Pes planus, we talked about that a little bit. It means flat feet. It's when the talar head displaces medially and plantarward. Stretching the spring ligament and the tibialis posterior occurs here, and you lose that medial longitudinal arch in your foot. And just a few pictures for you. Hallux valgus is a diagnosis that you'll see oftentimes with typically with the older population. Lateral deviation of the great toe occurs here, so as you can tell, this great toe is deviating out, or lateral. It should be straight out in front, and it's not. And then a lot of times you'll see bunions forming on that area, and there's no room for the second toe to go anywhere, and so it ends up being placed up over or on top of the great toe and the third phalanx. More toe deformities that you guys need to be able to recognize on an exam, and just once you become a therapist: claw toe, hammer toe, and mallet toe. And again, we'll talk about those in class. And then bone spurs, exostosis. This is abnormal bony outgrowth. It occurs in response to either overuse. It can occur because of trauma or too much pressure on a bony landmark or in an area. Common locations: the dorsal tarsometatarsal joint, excuse me, the head of the fifth metatarsal, calcaneus, at the insertion of the plantar fascia, which is a big one actually, because this can create plantar fasciitis as well. And then the superior navicular bone. And a scenario, go ahead and read through this, and we will discuss in class.